Topic of discussion is organ donation and transplant. I will discuss this in three parts uh, for ease of discussion. Let's start with on case scenario first. So you will face around 2 to 3 questions from this topic. This is an important one. So let's start with this case scenario. Say like Mr. David, 40-year-old, previously healthy man, got to emergency following a motor vehicle accident. He was driving alone and had a road traffic accident. GCS is fluid on admission. He was intubated and vitals were unstable, required fluid resuscitation, vasopressor to maintain adequate blood pressure. And on neurological evaluation, he was there was no response to painful stimuli. Pupils were dilated and fixed. Brainstem reflex were absent, and there were no signs of improvement of neurological function. CT scan and brain imaging was done, revealed diffuse axonal injury, extensive intracranial hemorrhages, and diffuse cerebral edema. EEG monitoring was done, which was flat pattern, isoelectric EEG pattern. So there was no neurological improvement after 72 hours. The neurology team, after conducting serial examinations and reviewing diagnostic findings, confirmed absence of any signs of brain function. So brain death was diagnosed following an internationally recognized criteria meeting all prerequisites of diagnosis. So this is the commonest scenario we often face in our day-to-day clinical practice. The patient with RTA with intracranial bleed and intracranial event presented with brain death. So let's, what is our what should be our next step of management? So first is breaking bad news in ICU, which requires sensitivity, empathy, and clear communication. So in this scenario, what is your common approach? What will be your next best appropriate management? So prepare and plan yourself, ensure a suitable environment for privacy and comfort. Be prepared with all relevant information and anticipate possible questions. Build rapport, introduce yourself to establish rapport. Assess family's understanding and readiness to receive information. Use clear and compassionate language. Use simple, straightforward language while avoiding medical jargons. Provide information in stages. Start with a warning shot and indicating the seriousness of news, and provide information stages, allowing time for understanding and emotional processing. The next is check understanding and offer support. Ask open-ended questions and involve a multidisciplinary team, including social workers and additional supports. Collaborate with healthcare team and consistent managing. So discuss next steps and options and follow up and documentation. This is the this should be your next step of management. So after family discussion and support, the medical team engage in empathic discussion with Mr. Thompson family, explaining the irreversible nature of his condition and diagnosis of brain death. They provide emotional support, allowing the family time to comprehend the situation and ask questions. Now comes the ethical consideration and organ donation discussion. So the medical team, respecting the family's emotional state, discuss the following option of organ donation, highlighting the potential to save lives through transplantation. They emphasized the opportunity to honor Mr. Thompson's legacy by helping others through donation. So, what do you mean by brain death? So, an individual who has sustained either irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of intrabrain, including brainstem, is death. Well, death in normally in ICU, we declare death by cardiopulmonary criteria is well understood to the relatives and laymen. But declaration of death by whole brain death criteria can be more problematic. Many families and religious groups are reluctant to accept this determination. So, in case of whole brain death criteria, you need to establish cerebral functions are absent, brainstem functions are absent, and irreversibility is recognized. I mean, the cause of coma is established and is sufficient to account for loss of brain function, and the possibility of recovery of any brain function must be excluded. So, what are the prerequisites for conducting a brain death test? Core body temperature should be maintained. We have to exclude all the reversible conditions. Absence of any confounding factors that might mimic brain death, like severe drug intoxication, metabolic disturbance, or use of any neuromuscular blockade sedatives. Primary cause of coma should be established, and there must be a significant observation period that should vary in case-to-case basis. So another important thing here is pillars of medical ethics. We have autonomy, beneficence, non-maleficence, and distributive justice. So you have to understand these four basic principles. I have included this because you can get questions out of this topic. So what are the common confounders of brain death? These are hypothermia, drug intoxication, overdose of variety of medications, metabolic milieu should be maintained, and any deep sedation, neuromuscular blockade. Patient is in locked-in state, and patient with GB syndrome or other neuromuscular weakness or neuromuscular disease. So after all the confounders has been excluded, hemostasis is normalized, and the patient is resuscitated. One must remember to document the temperature and blood pressure before each examination of apnea test. First, an unresponsive and comatose state without motor response should be verified. Central painful stimulation should neither elicit any eye opening or not any purposeful or reflexive movements, and there should not there should be no spontaneous movement in cranial territory or no signs of seizure activity. So these are the normal things. All brainstem reflexes must then be tested on both sides to verify any complete cessation of all brainstem function. It includes absence of midbrain function by lack of pupillary reflex, pontine function, lack of corneal reflex, and caloric and vestibular reactivity, and medullary function by lack of cough and gag reflex. So the sequence of apnea test should be repeated within 124 hours. Short intervals may be appropriate in catastrophic condition. A longer duration is recommended in children in post-cardiac arrest patient. So we all know about the apnea test. Apnea test is important because you can get questions about apnea test. You have to know the common thing that we often perform in our IQ. After excluding all the confounders and meeting all the prerequisites, apnea test should be continued, and PCO2 above 60 or a rise of more than 20 detects that apnea test is positive. So there are certain reflexive movement you should be aware of, including triple flexion of lower limb, and there are some extension pronation movement of arms. These are mainly made from the spinal reflexes. So this doesn't rule out any negativity of apnea test. And another important here is Lazarus sign. It's an abdominal flexion, adduction, and flexion of arms, and it's sometimes it can mimic some response. So you should have these things. And the most common method of confirming brain death is by lack of effective intracranial perfusion that we can We can do it traditionally by cerebral angiography, CT angiography, and transcranial Doppler. These are ancillary things. And in patients where you can not do apnea test, these ancillary tests might help, including EEG things. So these are the basic things, and we have now we will discuss how to manage a patient who is brain dead and with potential organ donor in details in our next session that I will discuss later. And here the most 2 to 3 important things I want to mention in exam perspective view. One is that neurogenic shock, it's the mechanism, and neurogenic pulmonary edema, and diabetes insipidus. These are 3 things that often you can get questions. So I will discuss these things in my next topic of discussion.